There we go. Just change your presentation.
Right.
Hello, can you hear me?
For some reason, it won't come back. The mouse won't come back. Anyway, we're just going to start and we will figure it out. Kathy, I don't know if you can give us a hand. The mouse won't come back to restart our presenter notes, but that's okay. So just as we're sorting out our technical start, hello everybody, and thanks so much for coming to Rounds. It's myself and Dr. Gibson presenting on the primary care diagnosis and management of common breast conditions. And as it is September 30th and the National Day of Truth and Reconciliation, we hope that you're having a reflective day. And we would like to acknowledge that we are giving this presentation from the traditional territory of the Anishinaabe people of this area, and we acknowledge from the
Can you hear me?
Saxing, Shawniga, and Henry First Nations who are very close, as well as the Washaw First Nation who's down the road. So thanks so much for joining us today. In terms of what we're going to talk about, we do, so I should say, I'm Dr. Champion. I'm sure many of you know me. My first name is Kate. I'm one of the general surgeons who works here. And I'm currently the general surgeon who's running the breast clinic, although we do have some locum support who have been helping with us on and off. And Dr. Gibson had been providing us excellent support in benign breast disease, but unfortunately is no longer able to help us on a regular basis. So she and I felt that it would be a good opportunity to take some time to talk about benign breast conditions, in particular because we just don't have the same capacity in breast clinic to talk about manage the benign patients that we used to, and so we'll talk about that a little bit more as what that means moving. So just in terms of disclosures, oh, now my slide isn't advancing over there. I don't know why we're having slide problems today. My apologies. Sorry, we just need to re-share. I can share. We just weren't advancing. I don't know what was happening. Because I'm advancing here, but I just can't see it there. So I'm assuming they can't see me.
No, they can see the PowerPoint.
There's that. Okay.
There, that's all you want.
But I can't advance it.
Oh,
Why can't it? There, I have to advance it that way. Okay. Sure. And then we'll just move this. Okay. Perfect. Progress. All right. So, oh, excuse me, I'm also getting over a cold. Why my voice sounds like crap. So in terms of our disclosures, I do have a grant studying frostbite from NOAMA, but no other specific disclosures. Dr. Gibson does not have any affiliation exposure or disclosures, and then both of us do receive financial support from the Perry Sound Leg and just our time involved in preparing for this session. So thank you to them. In terms of our learning objectives, we wanted to take you through a clear and complete approach to the evaluation and management of common benign breast conditions. We wanted to help you identify indications for surgical referral of common benign breast conditions. We wanted to describe an approach to breast cancer surveillance and survivorship, including the indications for specialist evaluation and referral, as well as describe local resources for collaborative management of patients presenting with breast cancer. Ola can't hear me, and I'm really sorry. I'm honestly speaking as loud as I can. So I will do my best, and hopefully that will improve. And I do have to wear a mask in an effort to not get Dr. Gibson and Kathy sick, because I don't want them to have what I have. So we'll start by talking about an approach to the history and physical exam of breast complaints. Then we'll talk about diagnosis and management of common breast conditions. So in particular, we wanted to make sure we touched on mastalgia, mastitis, breast cysts, breast abscesses, fibroadenomas, nipple discharge. If we have time, we'll talk about benign breast biopsy and what kind of the key principles are. But I've deferred that to the end, provided we have time. And then we'll also talk about breast cancer surveillance and survivorship. I would also like to chat with you and share some adjustments that we would like to make to the breast clinic referrals and discharge plans. Again, we were very fortunate for many years to have Dr. Gibson's amazing help in following up a lot of these benign conditions. But now that we no longer have the capacity to do that, we are in a position where we have to put some more focus on the surgical patients. But having said that, my goal in this talk and our goal is really to help empower you as primary care providers to work within the full scope of your practice and managing these things, because I think these are all things that you can manage very effectively. It's just a matter of having some knowledge of kind of what's normal, what's abnormal, and where to ask for help. And certainly in the breast clinic, we're happy to provide help at any time and additional support, and then send the patient back to you as appropriate. So well, we'll hand it over to Dr. Gibson, who's going to start with taking us through a breast history, and we'll go from there.
Thanks, Kate. Okay, so I am going to attempt to be able to read my notes here. Guess that might not be possible. We're not using this at all.
So
Okay, so there's no way to advance these ones. I'm just ignoring this screen. That's okay, I can use this. No, it's all good. It's all good. Yeah, no worries. It's all good. Okay, so I'm just gonna pull up the presentation on my own screen just so that I can have my notes. So I thought I would start, first of all, thank you, Dr. Champion, for the introduction. I also just want to mention both of us are happy to be interrupted at any point if you have questions, or you can save them to the end, whatever your preference is. So to start off today, I'm going to just chat about taking a breast history. So these are the main symptoms or signs I would want to ask a patient about. So lumps or masses that they can feel, and then of course you'd want to characterize those by size, shape, contour, mobility, adherence to the chest wall, or tenderness. And then nipple changes such as flattening or inversion, nipple crusting or discharge, and then you would want to further qualify that by assessing if the discharge is unilateral versus bilateral, uniductal versus multiductal, spontaneous versus non-spontaneous, bloody versus non-bloody. And I'll just throw a quick caveat in to say that most women, if they squeeze their breast, something will come out. So really the spontaneity of nipple discharge is an important part of the history. You want to ask about skin changes in and around the breast and nipple areolar complex, such as dimpling, swelling, redness, or rash. You'd like to ask about pain and qualify if that pain is cyclical, non-cyclical, or extramammary if you can. You may want to ask about systemic symptoms. Do they have fevers, chills, night sweats, unintentional weight loss, abdominal pain, or bone pain? Of course, you want to assess their breast cancer risk by identifying any risk factors they may have, such as age, race, age at menarche, parity, age at the time of first childbirth, breastfeeding duration, age at menopause, use of supplemental hormones like oral contraceptives or HRT, radiation history to the chest wall, of course, any past medical history of breast biopsies with and without atypia. So knowing pathology is important if that's available. Obviously, knowing if they have a breast cancer history already or any other cancer history, specifically endometrial or ovarian. Wondering if they have a family history of breast, endometrial, or ovarian cancer, specifically in first-degree relatives, and if there was any BRCA association in the genetics of those cancers. And then finally, important to identify if there are any associated conditions such as pregnancy, menopause, or previous or recent breast procedures. Okay. Perfect. So in performing a breast exam, my approach and everyone's approach is slightly different. I think the main takeaway is that your approach should be organized and consistent over time, and that position matters. So for performing a breast exam, I often have the patient fully undressed from the waist up and put on a gown with the gown closure at the front. I start with the patient in a seated position and I first assess their lymph nodes. So checking cervical, supraclavicular, infraclavicular, brachial, and axillary lymph nodes. And then I'll generally observe the breasts with their arms resting at their side, raised overhead, and stationed on their hips. I'll look at breast size, shape, contour, and symmetry, noting that there's always a very slight asymmetry between two breasts. I will assess the skin overlying the breasts. So for any dimpling, edema, erythema, rash, or abnormal skin lesions and ulcers. I will look at the nipples and the nipple areolar complex to assess for any inversion, flattening, eversion, crusting, discharge, skin changes. And then I will palpate the breasts themselves using superficial and deep palpation in some form of an organized manner. And then sometimes we'll also add on a brief musculoskeletal examination, such as palpation of the chest wall muscles like the lats and the serratus anterior, and assessing range of motion of the shoulders and lymphedema specifically in post-surgical patients. Sorry, and then what I will have the patient do, if they are willing and able, is I will have them lay down on the bed and perform palpation of the breast in a supine position as well. Again, just staying consistent with my approach to that. So the first condition I would like to talk about today is mastalgia. This was by far the most common referral that I received when I was working in the breast clinic. Mastalgia is very common and largely benign. It is rarely a symptom of breast cancer. Important to differentiate cyclical mastalgia from non-cyclical mastalgia from extramammary mastalgia. 2/3 of the time, your cases of mastalgia will be cyclical. These tend to be related to the menstrual cycle and typically peak mid-cycle or the week before expected menses. Often the discomfort is bilateral and most severe in the upper outer quadrants. 1/3 of the time, the cases of mastalgia will be non-cyclical, meaning unrelated to the menstrual cycle. The discomfort may be constant or intermittent. It could be unilateral and variable in its location in the breast. Some etiologies include, but are not limited to, macromastia because of stretching of Cooper's ligaments. And if you'd like to review your anatomy of the breast, you can do that. Lifestyle issues. Some people have proposed high-fat diets, caffeine intake, and smoking as possible reasons. Of course, pregnancy and menopause can result in mastalgia. Use of HRT or OCP, and then underlying breast conditions like cysts, ductal mastitis, and all of those other things. Non-cyclical mastalgia often resolves on its own, especially if it's related to things like pregnancy, menopause. And then you could also identify if there are extramammary causes of mastalgia, meaning referred pain from the chest wall, the lungs, the heart, the gastrointestinal system, the biliary system, and or the spinal and paraspinal conditions. And then in men, mastalgia most of the time is related to gynecomastia. And we aren't touching on gynecomastia today specifically, but anyways, for another time perhaps. In patients who present with mastalgia, our first approach beyond history and physical examination is imaging. We would choose first ultrasound plus or minus mammography if the patient is over the age of 35. Less than 35, often their breasts are too dense to be able to identify anything specific. And then if you're ever in doubt about the etiology of the mastalgia, it's better to just go ahead and image. All right, so treatment of mastalgia. Reassurance provides adequate relief for up to 85% of women who present with breast pain. 15% often require further treatment due to the pain interfering with their daily living. And an interesting quote I came across while I was reading about this on UpToDate rather, was that women who present with breast pain, but who have a normal physical examination and imaging studies can be reasonably assured that their risk of breast cancer is similar to that of a woman without breast pain. So reassurance is the #1 form of treatment for mastalgia. Other forms of treatment for mastalgia are listed on this slide. Treatment is largely supportive in the absence of an underlying breast pathology, and we'll get to other pathologies later. Physical support, I will often ask them to change from an underwire bra to a wireless or sports bra if they are wearing that, or vice versa. I'll often also ask them to wear not a very compressive bra, but some form of support like a bralette at nighttime. They can use warm or cool compresses, whichever they get more relief from. They can do self-gentle massage or have their partner perform self-gentle massage with or without the use of vitamin E. I find vitamin E oil in and of itself is quite expensive, but there's a decent amount of vitamin E in coconut oil, which is much more economical for most people. Over-the-counter analgesics in both topical and oral forms are reasonable. You could perhaps make some suggestions around decreasing dietary fat, decreasing caffeine intake, and smoking cessation, though there's minimal but evidence around them, they're fairly harmless. And then addressing exogenous estrogen use if that's present, and then if you believe there may be an MSK component, suggesting activity modification or physiotherapy. Moving on to mastitis, there are essentially 2 forms of mastitis, lactational and non-lactational. Lactational obviously being associated with breastfeeding, often due to prolonged engorgement or poor drainage of the breast. You can see that it's an acute onset of unilateral, usually, breast pain, redness, swelling, firmness. There may be systemic complaints, including fever, chills, myalgias, malaise, and flu-like symptoms. Treatment for lactational mastitis is both supportive as well as medical. Supportive treatment would include emptying the breast completely, so encouraging ongoing breastfeeding, pumping, and hand expression. Cool compresses, specifically cool, warm tends to actually create a milk letdown, and so using cool to try to decrease the engorgement and lessen the pain. Anti-inflammatories, if that's appropriate for the patient. And then antibiotics. The pathogens most common are MSSA and MRSA, and the antibiotics are listed here for you. I think depending on the severity, you could obtain a breast milk culture to help guide your prescribing. I'll be honest, I've never done that. And the average length of treatment is about 10 days. If a patient has been treated or is recurrently presenting with presumed mastitis, it may just trigger you to consider the possibility of inflammatory breast cancer. And then non-lactational mastitis is mastitis that occurs in the absence of a breastfeeding patient or the absence of nursing, often related to periductal mastitis, idiopathic granulomatous mastitis, and tuberculous mastitis. I have never seen any of those. Perhaps Dr. Champion has. And if I ever did suspect any of them, I would be referring them on to someone much smarter than myself. This is a very busy slide, and I would encourage you to take time on your own to familiarize yourself with this graph. It's available readily on UpToDate, and it's amazing. I referred to it almost daily when I was working at the breast clinic. So breast cysts are very common, probably the second most common referral we would get. Most common in pre and perimenopausal women and any postmenopausal women who are taking HRT. It is generally considered normal in the presence of hormonal influences. So I would frequently tell young women in breast clinic that if you're still getting a period, then it's normal for your body to make cysts and get rid of cysts on its own. Cysts are solitary fluid-filled masses or multiple fluid-filled masses. They can vary in size and location. They're variable in terms of their symptomology. Some have no symptoms whatsoever, and others can be associated with pain or inflammation. Imaging is primarily ultrasound and mammography, and this will help identify the classification of the breast cyst, and that's where we can start to use this table. So hopefully the radiologist reading the images will identify a cyst as either simple or complicated, and will also give the cyst a BI-RADS score. Simple cysts tend to be well circumscribed with posterior acoustic enhancement, anechoic with no solid components, no Doppler signal, and tend to be BI-RADS 2. Complicated is the opposite of that. So they may have low level internal echoes, there may be echogenic debris, there may be some walls, though usually thin, or some septa, though usually thin. Usually still no solid components and still no Doppler signal. And then those could be identified as BI-RADS 2 or 3. And then complex is where it's still a fluid-filled lesion, but there may be possible lobulations, thick walls or thick septa, cystic and solid components, perhaps a Doppler signal. And all of these will be characterized on the radiology report, hopefully. Those are often characterized as a BI-RADS 4+, therefore they require some form of biopsy and concordance reporting. So you would really just follow this graph all the way down to the bottom. Basically, if you have BI-RADS 2, there's no further investigation. You could FNA it if the patient was very symptomatic, and if there was collapse, then it's considered benign, no further investigations are following. If it's a BI-RADS 2 or 3, you may consider FNA if the patient's super symptomatic. If the FNA is non-bloody fluid, and again, it collapses under FNA, it's considered benign and warrants no further investigation. If you don't FNA it, you can just follow it every 6 months for 1 to 2 years, or until it's downgraded from a BI-RADS 3 to a BI-RADS 2. And then for complex, like I said, these are usually characterized as BI-RADS 4 lesions and require biopsy and concordancy. Risk of breast cancer still in BI-RADS 4 patients is somewhere from less than 1% to 23%. So nobody usually likes to juggle a quarter for a 25% chance of breast cancer. That's why we biopsy them. And the most common etiologies of a BI-RADS 4 cyst are actually abscesses, hematomas, fat necrosis, galactoseals, ductictasia, or oil cysts. So FNAs, we really only suggest if the patient is super symptomatic or wishes for an FNA. It can be both therapeutic in the case of an acutely inflamed or painful cyst, as well as diagnostic. And basically any FNA that identifies non-bloody fluid and it results in complete collapse of the mass is considered simple and warrants no further investigation. Okay, so that's my part's done. So I'm going to hand it back to Dr. Champion, and she's going to move on to some more complex issues.
So I would just like to add on the topic of breast cysts that we do have our radiologist here every Tuesday. And I think if you're seeing a patient in clinic with a breast cyst, it is a good, and if they haven't had imaging, it is a good idea to get them some imaging, because you want to make sure that you're not just blindly draining something that turns out to be a complex cyst that's a BI-RADS 4 that truly requires a core needle biopsy. So I do think it's reasonable if you have these patients and you'd like them evaluated in breast clinic to send a referral to breast clinic, but also to send a referral to the radiologist at the same time for consideration of ultrasound imaging and a drainage, ultrasound guided drainage. And then that way they're able to take a look and assess, and if they can just drain it, they do. And if it's something that requires a little bit more complex biopsies, then they sort that out as well. So that's very helpful. So from an abscess perspective, these patients generally present with breast pain, erythema, swelling, and they may or may not have a fluctuant mass. And ultimately you end up with a diagnosis on ultrasound plus minus mammo. Generally, ultrasound is your most helpful thing. Mammos are very painful often for these patients. But if you have a patient who's over 50, if it's over 50 for sure and over 40, and who hasn't had a mammo in a while, I think it's reasonable to consider a mammo as well. Ultimately, the treatment that's preferred is an ultrasound guided needle aspiration. So this is done by radiology, as opposed to just opening it. If you just make a cut and overline the skin and let it drain, then it has the risk of turning into a milk duct fistula and being a more complicated fistula process that's harder to treat over time. So generally, the needle guided aspiration is less invasive, gets rid of the purulent component to allow your antibiotics to work better. And even though it may take a few attempts at drainage, ultimately avoiding that potential complication of a milk duct fistula is preferable. I will say beware the periductal mastitis. So this is the patient who comes to you and their abscesses, they seem to have multiple abscesses. They're often subareolar. Sometimes they can have purulent discharge from the nipple itself. And the treatment for these patients is typically antibiotics and smoking cessation. Most of them are smokers. I have seen them in men as well as women. But again, I would have I wouldn't just kind of take a knife to them and say, okay, just drain this. I think it's important to recognize that if they keep having these periareolar or subareolar abscesses, then you're probably looking at periductal mastitis as opposed to a simple abscess, in which case honestly the mainstay of treatment is smoking cessation. When it comes to fibroadenomas, these are very common, particularly in young women, usually can be found in their 20s and 30s and often into their 40s as well. The nice thing is that when these are palpable, which is usually in the setting where they're kind of 2 centimeters or more for sure, 1.5 centimeter lesions you can feel. If they're a centimeter or less, to be honest with you, it's pretty hard to feel any of those lesions. But they feel very smooth. They're hypermobile. So what I mean by that is they really move within the breast tissue. When you're doing your breast exam, you'll feel them pop back and forth, and that's consistent with a fibroadenoma. Ultimately, you do need a diagnosis on imaging. As with any person presenting with a mass, it's a good idea to get an ultrasound mammogram. For young women in their 20s and 30s, a mammogram is often less likely to be helpful. I would start with an ultrasound, but certainly anyone who's over 40 for sure, I would get a mammogram. And for someone in their 30s, to be honest with you, it's worth trying. Sometimes they can see things clearly, sometimes they can't. You can consider a core needle biopsy to confirm the diagnosis if the patient is over 35. But you can, if they're characteristic of fibroadenomas, also just reasonably follow them on follow-up imaging. Ultimately, the indications for surgical excision comes down to what is the size. If they're more than 3 centimeters, to be honest with you, they're more likely to be symptomatic. They're more likely to be a bit abnormal. And so it's rare the patient who has a more than 3 centimeters fibroadenoma that's totally stable without any concerning features, that they don't have symptoms. Most patients at 3 centimeters would have symptoms, and it's usually tenderness related to the fibroadenoma itself, and the patient can feel with pressure on that area from clothing, wearing a bra, etc. That is uncomfortable. Rapid growth is also another concerning feature, because fibroadenomas can fool you, and they can turn out to be phylloides tumors in very rare cases. Usually you'll find on history that this person says, oh, I had a mass here and it's been growing significantly and quickly over the past few months. That's less likely to be a fibroadenoma, more likely to be a phylloides tumor. And so that's why in the setting where we don't have to take it out, so it's say like 1 centimeter in size, the patient hasn't endorsed any growth, and maybe they presented with cyclic mastalgia, they had an ultrasound and this was incidentally found on the ultrasound, then generally the recommendation is to repeat the ultrasound in 6 months. at 12 months from their initial imaging, so another 6 months after that, and then 24 months from their initial imaging, which is a year after that, just to document stability. And again, if there are any changes in terms of significant growth, that would be something to say, you know what, this probably should be sent to a surgeon for excision because we want to make sure we're not missing a phyllodes tumor. But again, those tumors are quite rare. When it comes to nipple discharge, Dr. Gibson talked about this a little bit. It's important to assess on history whether it's unilateral versus bilateral, whether it's spontaneous versus expressed, whether it's bloody or non-bloody, multiple versus single duct. So they say, yeah, it kind of comes out from anywhere when I press anywhere versus I always press in the same spot and it comes out the same spot on the nipple. It is important to recognize that expressed non-bloody discharge is not pathologic. No further workup is required. The patient should just be instructed to stop manually expressing and observe. And if that patient is over 40, you can consider a screening mammogram just from their general screening health, but it does not require specific further investigation. The stuff that does require further investigation in particular is really the spontaneous discharge, and in particular from a breast cancer perspective, I worry the most about unilateral bloody spontaneous discharge. That to me is kind of breast cancer until we've done the workup and figured it out otherwise. Although oftentimes that can be related to things like a papillary adenoma and other pathology of the duct. So it's not pathognomonic for breast cancer, but it's certainly concerning and needs to be taken seriously. And then in terms of treatment, if there is concern for a mass on imaging, then typically they end up with a core needle biopsy. Indications for surgical management, as I alluded to, is really bloody discharge because we're concerned for a cancer, persistent symptomatic discharge, or there's a mass that requires excision on core needle biopsy. So it's not uncommon that patients can have papillary adenomas, and these can result in persistent symptomatic discharge or bloody discharge, in which case it's reasonable to take them out even if on biopsy they're benign, just from a symptomatic perspective. And this wouldn't be something that you would be doing in a primary care setting, but certainly when I talk to these patients about surgery, I talk to them about excising the duct versus and trying to target it, or you can, sometimes we can't target it and we have to do a complete ductal excision. And if that's the case, then they're still in their family planning years and planning to breastfeed at a later date, that can compromise their ability to breastfeed. So I always talk to them about that. And in terms of non-operative management, so that would be in the patient that has persistent discharge, but you know what, they're not really worried about it. It's not bloody. They don't find it bothersome. It kind of comes and goes. We haven't found a mass or some other reason that we have to take them to the operating room. It is reasonable just to do follow-up imaging and a clinical breast exam every 6 months for about 1 to 2 years, just to check and make sure that there isn't a lesion that has evolved over that time. But there is a subset of patients who at the end of the day say, I just want to know it's not breast cancer. And as long as it's not breast cancer, I can totally manage this. It's fine and it's not bothering me. And that's totally reasonable. So I also wanted to talk about breast cancer surveillance because this is something that we currently in the breast clinic, we follow people for up to 5 years. The reality is that these patients really are at the highest risk of recurrence within 2 years of treatment. So we had been shifting to Dr. Gibson doing the follow-ups for most of these patients after 2 years. And then obviously getting the surgeon re-involved if there's any concern at any point about there being a local recurrence or a nodal recurrence. In general, it's good to understand the pathology in terms of the surgical and oncology treatment factors. So these are what ultimately influence the type of surgery they get and the type of adjuvant therapy they get. So it comes down to the size of the lesion, whether or not there are lymph nodes involved on sentinel lymph node biopsy, what the tumor receptors are. This is really important for the medical oncology decision making. So estrogen and progesterone receptors, and then HER2. If a patient is hormone receptor, so ERPR positive, then typically they would get tamoxifen or an aromatase inhibitor. And if they're HER2 positive, then sometimes they get neoadjuvant or upfront treatment with Herceptin, or they get adjuvant Herceptin afterwards. And then some of it comes down to patient preference as well. And I always enjoy the 90-year-old ladies who come in to see me with a palpable lump that they could easily have a lumpectomy for, that they're just like, you know what, I don't care, just take it off. I want to do a mastectomy. I don't want to care about radiation afterwards, because I don't feel like driving to Sudbury. And I say, you know what, 90-year-old lady, that's totally fair. We'll do that. So surveillance it starts after the initial treatment is complete. So this is really for most patients, this is the surgical treatment. And then after they've completed surgery, then they go on to chemotherapy, but we would consider their surveillance starting after their initial surgical treatment. And in the case of patients who are getting neoadjuvant therapy, so upfront chemotherapy followed by surgery, again, we would follow them, but then they would get their surgery and their surveillance interval would start after surgery. So after their surgery, we generally see them every 6 months. We want to go through a history in particular of making sure that there are no new masses or changes to the breast. So I always ask people about that good full breast history, skin changes, nipple discharge, and any concern they have with lumps in their axilla or their underarms where we've done the sentinel node biopsies. We also want to ask about systemic symptoms concerning for metastatic disease, so abdominal or body pain, headaches, neurological changes, shortness of breath, cough, vaginal bleeding. Although I would say that's extremely rare in someone who hasn't had any nodal metastases, and the vast majority of patients we see with breast cancer are screen detected breast cancers, and most often they have none or very minimal involvement of the lymph nodes. Having said that, you can always develop metastatic disease even if you have no lymph node involvement. Weirdly, it can happen. So it is important just to be aware of asking patients these things. And then you do a clinical breast exam at the same time. So that's every 6 months. And then you do get an annual mammogram starting 1 year after surgery. In general, I think it's important to wait that 1 year because it's not uncommon, particularly with women who undergo lumpectomy and get radiation, that they have additional scarring and changes within the breast that take some time to settle out. And doing imaging prematurely, we often end up seeing post-op hematomas or seromas or other scar tissue and surgical changes that haven't had time to settle out yet, and often result in unnecessary investigations for patients. So my general rule is that we do a 1 year anniversary mammogram on the year after. And again, the risk of recurrence being the highest within the initial 2 years of treatment. So in terms of surveillance, again, those things to watch out for, particularly local recurrence, nodal recurrence, systemic issues that patients can run into that require either surgical reassessment or medical oncology reassessment. These are things like a new breast or axillary mass or significant skin changes. So that peau d'orange you saw in the picture that Dr. Gibson had, although all patients who have had radiation will have some thickening of the skin that's normal, and as long as that's stable, that's fine. But if at any time you ever had any concern about a previous breast cancer patient having a new breast or axillary mass or concerning skin changes, please order a mammogram and ultrasound and refer them back to the breast clinic. In terms of new ipsilateral arm swelling, so this is a sign that's concerning for either a DVT, which is can happen particularly with patients on tamoxifen, or is concerning for nodal recurrence. So it's good to get both ultrasound and CT imaging to assess the vasculature and then also assess the nodes. And if there is a concern for nodal recurrence, that's something that needs to be discussed in breast clinic. and also needs to be referred to medical oncology because that ends up often being a multidisciplinary discussion. And generally, the breast cancer surveillance patients, certainly in Sudbury, are pretty well followed by their medical oncologist generally for 5 years. Although there is some variation between oncologists and not. With abnormal vaginal bleeding, excuse me, excuse me, this can be concerning for a uterine malignancy. If the patient is on tamoxifen, stop their tamoxifen and refer to gynae. Make sure you get a transvaginal ultrasound, refer to gynae if there's persistent bleeding or a thickened endometrium concerning for potential malignancy. New persistent bony pain can be concerning for bony metastases. I think a CT chest abdo-pelvis is usually the most helpful first step. Bone scans can be helpful adjuncts if you're not sure if they're metastatic nodules or what's being picked up on the CT. But I would start with the CT, start with some blood work, and refer to the medical oncologist if there's concern for metastases, because ultimately this patient needs systemic treatment. Unresolved shortness of breath or cough, get a chest x-ray to start, and certainly get a CT scan if your chest x-ray is negative and the cough is persisting, because you want to make sure you haven't missed metastatic disease. And then if there is concern for metastatic disease or a PE in patients on tamoxifen, you would stop the tamoxifen and make sure that these patients get referred back to medical oncology. Anyone who has new persistent abdominal pain, nausea, vomiting, weight loss over 10 pounds in 3 months can represent peritoneal metastatic disease or liver mets, and so CT of the chest, abdomen, and pelvis is helpful with, again, referral if there's mets. Similarly, with headaches or unexplained neurologic changes, the CT head is going to be the most helpful imaging there. So, what's the difference between surveillance and survivorship? Breast cancer survivorship means that you're 5 years out from your initial treatment, you haven't had any concerns for local recurrence or nodal recurrence, you're doing well. Then we do recommend that you have ongoing survivorship follow-up. So this involves an annual history, clinical breast exam, and a mammogram. And if you have patients who are at 5 years, of treatment with their tamoxifen or their aromatase inhibitor, it's often a good idea to make sure that they get a reassessment by medical oncology to discuss extension of their hormonal therapy up to 10 years. That doesn't mean every patient is going to do it or it's the right answer for every patient, but I think it's definitely worth the discussion, and the medical oncologists are generally pretty happy to do that. I have found in Sudbury, they often will kind of do it unprompted. I think with Simcoe Muskoka, you do have to request it specifically, so it's a bit oncology program dependent. But that's a nice thing just to kind of have flagged in the back of your mind. So at this point, I wanted to chat about some adjustments we were hoping to make for the breast clinic referrals and discharges. I am going to send a letter out to all of you along with copies of the planned paperwork for the discharge paperwork that people would get, as well as these referrals and discharge criteria, just to give you the opportunity to review it. I'm hoping that we can put these changes in place by the end of October, but want you to have the opportunity to make sure that things are complete, we're meeting your needs, while also recognizing that we do have limitations in our capacity with a single surgeon clinic. And that I do think that all of you are very capable of following a lot of these benign issues in the community. I'm certainly happy to help you do that and support you in doing that at any time. So in terms of who to refer, I think new palpable masses or concerning skin or nipple changes on clinical breast exam are a reason to send people. Breast imaging findings, so you've done imaging and they have a BI-RADS 4 or higher, those patients need a core needle biopsy, because I'm sure you're aware from reading breast imaging reports that breast imaging flavors come on a scale of basically 1 to 5, 1 meaning totally fine, no issues whatsoever. I think we very rarely see people with a true 5. I think most people have a little bit of something, meaning that it's a BI-RADS 2, nothing to worry about, but and they can have regular screening. BI-RADS 3 usually means it's something that needs ongoing follow-up with 6-month imaging. BI-RADS 4 means a corneal biopsy, and BI-RADS 5 means this is very concerning for malignancy and most definitely needs to be seen in breast clinic. Perfect. Yes, because the BI-RADS 0 means generally that they're not entirely sure what they're looking at and they want further imaging. And in the case of OBSP patients, generally it's that they want compression views or some other specific radiology view. New nipple discharge, with the exception of the express nipple discharge, which we have agreed is non-pathologic and patients should just stop squeezing their nipples and move on. That spontaneous nipple discharge would be a reason to see us. A breast abscess or a symptomatic cyst, and as I alluded to earlier, I would also recommend concurrently doing a request to radiology for an urgent ultrasound plus minus drainage. They are here on Tuesdays, so generally they're able to see a patient in a reasonable amount of time. And then new palpable or symptomatic fibroadenomas would be a reason for us to see people as well. In general, if this patient hasn't had a mammogram or ultrasound within 2 months of the referral, it's probably a reasonable idea to get them new imaging just to make sure that there hasn't been anything missed on their other imaging. And then that way they come to clinic with all of the information we need to determine the next steps in their care. In terms of discharge criteria, so the people who we see in breast clinic and then I think are very reasonable for you to continue to follow and support managing in the community are fibroadenomas without indication for surgical management. So as we talked about earlier, not every fibroadenoma has to come out. And it's not uncommon that you have people who have these small kind of 0.5, 1 centimeter up to even 1.5 centimeter fibroadenomas that are non-palpable in the setting of cyclical mastalgia that don't require surgical management. They aren't going to change their cyclical mastalgia. And these patients are generally called BI-RADS 3 and I think very reasonable to be followed up in primary care. Nipple discharge in patients without indication for surgical management. So as we talked about, these are the patients with the non-bloody unilateral discharge that happens very rarely, that there's no underlying concern on imaging and they're not bothered by it. And these patients can also be followed in a primary care setting. Benign breast biopsies. So this is someone maybe who had a BI-RADS 4, had a biopsy that was normal. In the breast clinic, we will make sure that we see them at 6 months. So we want to make sure that we do a 6-month follow-up imaging to make sure nothing has changed. There's no persistent lesions of concern, but it's not uncommon that these patients then get a follow-up saying, well, it's a BI-RADS 3, they probably should have a 6-month follow-up, but there's nothing that really truly requires surgical intervention. Again, I think it's reasonable for these patients to be seen in follow-up and have imaging follow-up in the primary care setting. And certainly if at any time there are any concerns with needing a repeat biopsy or new masses or things like that, we're happy to see them at any time. And again, following up those general BI-RADS 3, not uncommon that we see people, they have imaging, they're BI-RADS 3, they need a 6-month follow-up imaging, but there's no indication or requirement for surgery. I think these patients are very appropriately and capably followed up. In terms of our breast cancer surveillance patients, in light of the fact that the concern for recurrence is really most commonly within those first 2 years. Past 2 years, I think it's reasonable for these patients to be followed in a primary care setting, like we talked with what we talked about, which is every 6 months a clinical breast exam and an annual mammogram. And then certainly we would be happy to see them at any time if there are any concerns that come up on the imaging or physical exam. And we can reassess them if you have any concerns at any point. Ultimately, all of these patients, whether they're benign or cancer patients, will be discharged with a discharge summary with specific follow-up instructions. And the patient will get a short patient-friendly version as well of what they can expect in follow-up for their care. And that will be sent to you in addition to their breast clinic note at the time of discharge. And again, I'm going to send this out to you with a letter over the next week to review, and you can let me know if there's anything else that you're missing, you feel is missing or needs to be added or changed to make it more helpful to you. Dr. Gibson very kindly helped me put it together and vetted it for me. And I did get some suggestions from other folks as well in terms of what they would find helpful in their practice. So I'm hoping that we have a good version, but it is still a final draft version, so very open to the comments and questions. So with that, we have about 8 minutes left. And so if anyone has any questions, we can chat about them now. And we can also chat. I have a slide on how benign breast biopsies work if anyone's interested in that. But I'll put it out to any questions.
If anyone has a question, just go ahead and unmute yourself and ask.
Yeah. And certainly you're welcome to text me with questions anytime. I think many of you already do that. My email, Dr. Gibson's email, and we're happy to help you with managing as well.
Kate and Katie, thanks for the presentation.
You're very welcome, Ola.
Yeah.
All right, we may as well just chat about benign breast biopsies just so you know how they work, because it's not uncommon patients have questions about them. So generally, these patients have a BI-RADS 4 or 5 lesion that's found on screening or in workup of a palpable mass. If that's the case, they need a core needle biopsy for a diagnosis, and specifically a core needle biopsy and not an FNA. And the reason being is that you need to get a full layer of cells to really determine whether something is malignant and invasive versus in situ disease, etc. So the core needle biopsy specifically is helpful, although I think in general, with the exception of the cysts, like no one is doing FNAs anymore. We have figured that out in medicine and moved past the incorrect use of FNA for the most part. In terms of kind of the key management principles, we want to make sure that we get the core needle results, that they then go to pathology. Pathology takes a look at it. The radiologist has to then take a look at it and say, yes, I think that this is representative and makes sense based on what I was looking at. And then I also, as the surgeon, have to put all of those things together and say, yes, I'm satisfied with this explanation. This makes sense to me based on my physical exam, the patient's history, the radiology report, and what the pathologist has said. And if at any point those things don't agree, we call that a discordance, where we say, okay, this doesn't make sense. Generally, we often start with a repeat core needle biopsy, or if the radiologist has concerns that they're not going to get a good repeat core needle biopsy, or we've done 2 core needle biopsies and we're still not satisfied, then that patient would end up with an excisional biopsy in the operating room, generally with a wire localization. And in general, pathology that comes back that's with anything that says atypia in it usually requires excision. There are some exceptions, like any good rule. But in general, if it says atypia, it's going to come out as an excisional biopsy, and that's to rule out an associated malignancy. Whenever we see these patients, we always have to do 6-month follow-up imaging to make sure that things are stable. There are no new lesions, because there is always the concern that even if we think that we're right, we think that we know what we're dealing with, we think that it's benign, there is always the chance that we could be missing something. And so we like to be cautious and not take that chance and do 6-month follow-up. So with that, that is all we have. So I will leave it open for a few minutes in case there are additional questions. And watch out for that information about adjustments to breast clinic referrals and discharge summaries. And I welcome your feedback. Oh, it looks like we might have. Oh, good.
Hello,
Yep.
everyone. I just want to use this opportunity to introduce Melanie, our pathologist assistant.
Oh, excellent. Welcome. Our pathology team is great, so I'm
Yeah,
sure
so-
that they're excellent.
Mikola Melnick. She already knows all of the names.
Hello, everybody.
Can you hear Mikola's voice?
Hello, everybody.
Hello.
Hello, hello.
Okay.
Welcome.
Thank you so much. Thank you.
All right, everybody, sorry, my voice. So have a good day.
Thank you, everybody, for attending. And just a reminder, our next set of rounds will be October 21st, and it's with Dr. Hans Clark, who'll be speaking on appropriate times to prescribe opioids. Thank you. Have a great weekend.